together, and Dr. Aditya Narula will manage all moderate.
And other members are Shubh Mehrotra sir, Sarup Patel sir, and Anup Agarwal sir to come on stage, please. Shubh sir, please. Sir, combine kar diya na sir. So I would like to call upon Dr. Narendra Singh Kushwaha sir for his talk on avoiding intraoperative periprosthetic fractures in THR.
Thank you, organizing team and Dr. Prasad sir. Today my topic is avoiding intra-periprosthetic fracture during THR. Let us understand how to prevent or treat intra-fractures in total hip arthroplasty. The first thing to understand is that prevention is better than cure, and prevention can be by understanding and practicing prevention. Such fractures are not common, rates ranging from 18% to in revision, in uncemented to and 1.7% in primary THA. In general, be more careful in revision and during uncemented THA. This article supports the view stated above additionally, adding that intra-fractures occur during femoral component insertions and majority involve the calcar. Banker classification is the right classification, divided into type A, B, and C. The pictorial diagrammatic representation is here. Since failing to plan is planning to fail, therefore, for perioperative fractures of greater or lesser trochanter, do a tension band wiring or double loop cerclage. For all fractures around the tip of the stem, a double length femoral stem with or without LCP will work fine. For fracture distal to the tip, the treatment of choice is LCP. In case of post-operative fractures, the preoperative planning, identify the risk factors. These are the conditions where there is a risk factor during the THA, the intra-fractures, inflammatory arthropathy, osteoporosis, metabolic bone disease, advanced age, osteolysis, infection, axial malalignment, previous surgical intervention, and female gender. Good quality orthogonal X-rays should be done. Therefore, this is the first tool to get a good quality X-rays, appropriately centered, orthogonal, gives an idea of the bone quality and quantity. Full length films are taken to detect axial malalignment, and CT scan and MRI quantify the bone quality, and DEXA quantify the bone mineral density. DOR classification helps to decide between the cemented and uncemented femoral stem, cemented being used if cortices are thin and uncemented if cortices are thick. Templating makes approximate correct size implant preoperatively. Intraoperative risk, stages at which the risk of fracture is highest during surgical dislocation, intramedullary canal preparation, insertion of processes, femoral and acetabular component, and during reduction of the joint, removal of existing prosthetic stem or cement in revision scenario, and presence of stress riser like screw holes, femoral deformity, osteolysis, or infection. How to reduce these risk factors to good preoperative planning? Identify risk factor, good surgical exposure, over-aiming to reduce hoop stress during the insertion of uncemented press-fit stems, avoid eccentric varus reaming, careful cement removal, using prophylactic cerclage wire or cables, and use image intensifier during revision surgery if required. Broaching technique, during broaching, don't be a hare, but be a turtle. Remember, slow and steady wins the race ultimately. Compaction technique has no advantage over broaching. Implant design. This is the evidence slide showing uncemented single base and double base shaped and loaded taper cemented stents are risk factors for periprosthetic fractures. Prophylactic cerclage wiring. Adjoint cerclage wiring increasing the resistance of the fracture by 20%. Acetabulum fractures. For saving the acetabulum, avoiding oversized implants or under-rimmed sockets, press-fit uncemented components, and hemispherical modern implant design need to be remembered as risk factors. This is cadaveric study. This experimental study emphasizes the use of appropriate reaming. A few cases before the end, this lady came to us with bipolar in situ, loose implant. After proper investigation, ruling out the infections, decided to do a total hip replacement. Long uncemented stem was used, and during reduction, this happens. Type B subtype 3 fractures occurred on the table. I was not prepared for that. Close the wound, give the long thigh brace. After 1 week, fracture was managed by variable angle locking compression plate. Cable wiring or cerclage wiring not used due to osteoporosis of the bone. Another case, 28-year ankylosed spondylitis bilateral hip. During the left side, calcar fracture was occurred, that is managed perioperatively by double loop cerclage wire. So take home message is identify all risk factors, look for presence of stress riser, plan accordingly, prepare for OT damage control, ensure proper armamentarium, adequate surgical exposure, careful broaching and implant insertion, look, listen and feel, careful reduction of the joint, because experience is the best teacher and best experience teaches the best lesson. Thank you for kind listening.
Excellent talk, Dr. Kushwaha. Now I'd like to call upon Dr. K.D. Tripathi, sir, for his talk on revision, total hip arthroplasty in periprosthetic fractures. Dr. K.D. Tripathi, sir. I think sir is not here, so we'll call upon the next person on stage, Dr. B.D. Chatterjee, sir, for his talk on femoral bone defect management in revision THR.
Good afternoon, and sincere thanks to Dr. Prashad and Dr. Vishal, and it's a real privilege to be here speaking for this audience. So, my brief will be on femoral bone defect management in revision total hip. Now, the two challenges which confront the surgeon in a revision scenario is soft tissue instability and bone defects, and both of them have to be addressed with appropriate strategies, which usually include some amount of constraint to overcome the soft tissue deficiencies and methods to get around the bone defects. So we've already seen today very lovely lectures on acetabular management, and my brief will be on the femoral defect management. Just I will show you this slide. We all know this. The Paprosky classification of femoral defect is very useful, and from type 1 to type 4 it gets worse. The most difficult one is the type 4, where there's hardly any bone left for fixation. And I think the key to this classification is that how much bone do you have left in the diaphysis to ensure an adequate fixation to overcome the metaphyseal bone defect. Now, what are the strategies for managing these defects? One of the very popular ones is to use a modular component where you can address the mismatch between the femoral and the diaphyseal regions. If you wish to get further fixation, you can use a fully coated stem. When the metaphysis is beyond redemption, then you have to depend on a distally fixed stem, and the popular design today is a titanium stem which is fluted and which is conical in shape. Impaction bone grafting used to be very popular, but today I think it is slowly being overcome or being replaced by different implants. And of course, in absolutely hopeless situations, you can either use an allograft prosthesis composite if you have access to an advanced bone bank, or you can use a modular megaprosthesis. Now, the modular femoral component, it was put forward by Cameron in 2002, and basically the stem was devised to address issues in dysplastic hip situation, but it has found very useful applications in the revision scenario. So fundamentally, it overcomes the metaphysio-diaphyseal mismatch because you address these regions independently, and then it gives you a mechanism to link the two so that you have a stable construct. Importantly, it avoids excessive diaphyseal reaming, and it prevents metaphyseal stress shielding. I think the problem with the purely distal fixing stem is very extensive metaphyseal stress shielding. The bone disappears, and then that leads to complications. So you need not use bone grafts in the vast majority of cases. However, it is unsuitable when you have too much of metaphyseal bone loss. Now, if you look at the literature, the clinical outcomes have been very, very encouraging. 92%, 94%, 97%, the figures speak for themselves. Now, so if we look at the Paprosky types 1 and 2, then they're relatively easier to handle. This is an example where both the socket and the stem had to be revised because of significant osteolysis, as you can see in the Gruen zones. Now, this was addressed with an S-ROM stem and an osteotomy, where you see the proximal fixation with the sleeve, which osteointegrates, and the distal fixation with the fluted stem. And importantly, this is version modular, so you can actually adjust the version by trial and error. Yet another example where the severe femoral metaphyseal defect has been addressed with an S-ROM type of stem, and I think the big advantage here is that it obviates the need for allografts. This is a situation which I think in our country we face very frequently, broken implants, where you have to sort of either go for a repeat osteosynthesis, but in elderly patients, and especially if you have a semi-arthritic hip, as you see in this, it's better to fix it. It's better to go for an arthroplasty, and the S-ROM again gives you a very good option. Now, coming to worst cases where you have a Paprosky type 3 or 4, here an example with severe osteolysis in a cemented hip, again managed with a long stem S-ROM. The S-ROM gives you modularity in various dimensions. As you can see here, we have used a Calcar sparing stem, so you have modularity of the vertical as well as the horizontal offset, as is clear from this X-ray. Another example where the stem has perforated through the femoral canal, and rather a difficult situation was handled again with an S-ROM stem after removing all the bone cement. Fortunately, we did not need to do an extended trochanteric osteotomy here. Again, extensive osteolysis in all the Gruen zones. Fortunately, the socket was well preserved, again managed with a long modular S-ROM stem. Again, a situation we face quite frequently, the monoblock non-modular bipolar implants. This is a Thompson's, which has been used. It's lasted a while, but it has eroded both through the acetabulum and the extensive osteolysis in the femur. We accepted a high hip center here, and the femoral defect again was addressed with a modular metaphysio-diaphyseal fixing stem. Another difficult situation where there was a pathological a periprosthetic fracture which was fixed, and that also failed, and again managed by removing everything and putting in an S-ROM stem. So coming to fully coated stems, it aims to achieve stability through fixation and osteointegration both at the metaphysis and diaphysis, and several studies have shown quite outstanding results. Some of them are shown here. An example of a failed stem where the reef system was used. This is a completely modular system, but it has additional fixation with distal screws, and it is completely coated with apatite and osteointegrates. Another example, broken stem managed with a reef. Coming to purely distal fixing stems, now this has to be used in extensive proximal femoral bone loss, but it requires at least 4 centimeters of diaphyseal bone to be able to give a strong enough hold. The femoral straightening osteotomy may be required when there is a varus molding of the shaft, and the proximal femoral bone augmentation with strut grafts are also recommended when there's too much of a bone loss. And then a multicentric study has shown a fairly good follow-up results. An example here of a failed cemented hip treated with an ETO and then fixation using a Wagner type of a non-modular distal fixing conical stem, which generally has very good results in literature. Another example here where a different kind of stem has been used, but one should be very cautious while using thick stems, scratch fit stems such as this, especially long ones, because they can fracture the distal femur, because the straight stems, they do not accommodate the anterior femoral bow. Impaction grafting was popular once upon a time, but it is highly technique dependent, and you need the proper instrumentation to have a successful outcome. This is just to show the technique where you fill in the defect with morcellized bone grafts, and then you have to impact it, and then finally go in with a cemented stem. To show you an example, this is a failed isoelastic THR, which was a classic failure actually, managed with an Exeter stem and impaction bone grafting. Another example of a failed Charnley, and this is also managed with a C stem and impaction bone grafting. Allograft prosthesis composite has to be used in the extensive, if the femur is too badly destroyed, but I personally do not have much experience on this. The problem is that this has a limited lifespan. It depends on incorporation of the allograft, but good results have been shown by certain authors. Modular megaprosthesis is becoming increasingly into use, but it has a problem of survivorship, and therefore it is an adequate technique in the elderly, but has to be used with caution in the younger patients. So in summary, femoral bone defects are frequently encountered in the revision total hip arthroplasty. Several satisfactory methods are available today. Selection of the technique depends on the extent and location of the bone defect. You have to remember the simpler techniques are more likely to succeed than complicated ones. Availability of bone banking is helpful, and the probability of subsequent revisions must be kept in mind, and that's where I think the use of bone grafts becomes very important. So I thank you for a patient hearing.
Thank you so much, sir. Beautifully explained. And now I would like to call upon Dr. K.T. Tripathi, sir, for his talk on revision total hip arthroplasty in periprosthetic fractures.
Thank you, Chair. This is the case presentation of periprosthetic fracture. You may intervene if you want in between. This was a patient of 70 years old male, and fell down after 10 years of arthroplasty, and this was the X-ray. It was a periprosthetic fracture, AP and lateral view. When we classified, it is B2 with the good bone stock. Further investigations to just rule out any infection, and there was no infection because it was my own case for the last 10 years in between follow-up, and further imaging was not needed. But if you want in a periprosthetic fracture, you can go ahead with this. Then we planned the surgery, and these were the steps we followed. And first removed the ETO of, I think it was a natural ETO due to the fall. But if you want, you can do the ETO if it is not coming out. And in these patients, even in the mid X-ray, you can see there is a long stem. So in these patients, you have to go for the very long ETO as well. And then do the implant removal, and then cement removal. You have to invest most of the time in the cement removal in all the stages, metaphyseal, diphyseal, and distal plug removal. And the workhorse is the hand tools. Take your time. remove the cement very slowly, just avoid any bone discontinuity, any bone fracture. And then after removal of the cement, if you want, you can, if you have, then the high-speed drills, ultrasonic tools, all these are fancy instruments. If you have, then you can use it, otherwise hand instruments are more than enough. And then this is the post-operative X-ray of this patient. This is another patient post-operative X-ray. So to conclude that the tapered fluted modular titanium stem is very popular in these periprosthetic fracture of B2 and B3. So lesson learned is that Vancouver is a very simple classification. If it is B1, you can do the ORIF, and if it is B2, then you can revive with the long stem. If it is B3, then you need the replacing the proximal femur or with the allograft or mega prosthesis. So that was the end, but there is a, after 11 weeks, patient came again to me with the fall. I thought it is again another periprosthetic fracture or it may be dislocation. I was not sure, went for X-ray, and this was the X-ray. I thought that whether there was subsidence and then patient fell down, or if he fell down then dislocated. Because in these patients, when I compared with the previous X-ray, there was no subsidence at all. So I thought that should I go for closed reduction, or I prepared for the revision. And I went for the closed reduction, but I was feared that if stem was not integrated, then it can come out. But 11 weeks, I think these stems, they have a good bone integration, and with the good force, I was able to reduce it. And then I put him on the Thomas for on abduction for 6 weeks, and then I removed the Thomas, and patient was doing quite well. So that was the follow-up after 6 weeks I don't have. So take home is that removal of the cement is quite tedious and frustrating in these patients, and you need a lot of patience and perseverance to remove the cement after removal of the implant. Then in these patients, if the second message is that you can go try for the closed reduction, but be ready for the another revision. Thank you. Thanks a lot for your patient hearing.
Thank you, Tripathi sir, for an excellent talk. Now I would like to call upon Dr. Manav sir for his presentation on conversion of failed primary hip to a revision hip.
So a very basic case, but a complication occurred with one of my friend. Sometimes, so sometimes you post a simple case and you're in trouble. That is the time you need to help your colleagues. So, a neck femur was posted, poor patient, government scheme, no money whatsoever. So, I got this intra-op picture. What to do? Excuse me, it's not coming neither there nor there. Function F5 उधर नहीं आ रहा है. Okay. So the cement had set in. It's a fixed bipolar, which was not fully seated. Now the hip cannot be reduced. I don't have, sir. This is the only picture I have because I was not there. It's a neck femur. He was doing a bipolar.
Ask them to move image and see what's happening. Put an image, intraoperative, and see what is happening. Why it is not gone in? What's the matter?
Okay. So the cement had set in.
Agreed, no problem, but still see the image.
So the next thing he did is this. So he passed in, he took that out, hammered it out, passed in rigid reamers, which the cement directed elsewhere and caused a fracture lower down. The whole shaft was broken.
He was not in picture till
So he tried to circulage that. The patient landed up in ICU. Counts were high, and she ran fever for 2 or 3 days. So what should be done for the patient? Because the doctor is worried, the patient is worried, and she doesn't have money.
So this seems to be a, either a pneumatic process or infection here, either of these two. Patient is in ICU and you said counts are high. Counts can be high because of various reasons, but if the cause might be local, we'll think of local first. Now it's an infected process with a fractured femur, with no neck, which I think cement, I do not know, cement fully taken out or no?
Cement was not taken out, sir.
Fully taken out.
No. He tried to remove cement with a reamer, a rigid reamer, and after he broke that, he just circulaged and came out.
Now, money or no money, we have to go with science.
Yeah.
So money or no money comes secondary. So first of all, if we are thinking of infection there, what I will do, get an ultrasound, look for any collection, if yes, aspirate, send for gram stain, culture. Even if it doesn't grow, if it is suspicious looking, I'll take it as infected because there was a lot of struggle on table. First of all, control infection. Debridement, take out the cement, local antibiotic beads, whatever. Convert to a gutter stone kind of situation. When you go inside, put some sort of circulage so that it stays there. Stage 2, when infection is controlled, then reconstruct. That will be my approach.
So, a week later, the count settled.
So I'm taking infection here,
Yeah.
not anywhere else.
Even I thought of, infection in my mind. So, but what I did was, I put a spacer and I did this. A periprosthetic plate and a spacer.
So my thought process was not to put an implant inside at that time of an infected situation. It's already a worst case scenario. Why to go ahead?
I think I would be scared to put so much metal in a potentially...
That was thought.
Even I
see-
thought of doing it, but sir, the circumstances were such we had to give something to the patient.
Right,
So,
so-
the counts came down. Came down. She was out of ICU. Blood has been transfused. There was no fever, and the look was not sick.
So coming back, so we do not want to convey the message there to the hall that if the counts came down and it was locally looking fine, with cement there, with initially thinking infection, that we have eradicated infection. We don't want to convey that message. Yes, with compromised circumstances, we did it, that's okay.
So, after that, she was discharged, and now she doesn't have enough resources for a revision scenario. So, she was out of picture for a year or so. This is around 8 months down the line. She is still on spacer. The wound has obviously healed. Gross osteopenia, and what we gave was this cemented primary, which was only thing she could have afforded.
No, it's okay.
And this is the only X-ray again I have, and functionally she is doing okay. This is at the time around a month.
So putting cemented is not inferior to any other
No,
implant?
not at all, not at all.
Totally acceptable.
But what I want to convey is that you can still convert some revision scenarios to a primary, and if you buy some time. So I bought some time, the fracture healed, the plate was there, so cemented worked for this patient.
Agreed.
That's a small case, sir.
With severe osteoporosis, cemented was a wiser choice, I would say, because uncemented stem, we were not too sure of purchase of the implant.
I think the good thing was that the infection subsided.
Yes, sir.
Despite being plate in place.
Yes.
And with the fracture in place, previous
And-
history, you will be a
and-
bit worried about banging the primary stem, which is
And-
uncemented.
The brighter side was that she was mobilized with partial weight bearing on a spacer, though she took a long time to come back, but finally this was the outcome.
So the,
For the audience, please do not use the Talwakar type of fixed bulkhead.
It's too broad, it sometimes doesn't go in.
Go for a modular bulkhead.
It's too broad, so it sometimes doesn't go that deep. Na?
It is better to use a Thompson than that kind of a...
mic to this side.
And then how to go ahead with that? Remove and do the cementless, other options.
Second stage, yeah. Second stage means if you have money, then why will you will not wait for 1 year, no?
Yeah.
You will not
Definitely.
get such an osteoporosis. Put a distal fixing stem, take it as a periprosthetic fracture kind, and then go ahead and fixation plus what you did. Fixation plus primary stem.
Thanks a lot.
Very well managed.
Thank you, sir.
So at that stage, what was supposed to do was supposed to knock out the implant and take out the cement.
I did it a week, 10 days later, before putting the spacer. At the same time, after. Took out.
Very well managed.
Thank you, sir.
Excellent case, Manav sir. I would like to call upon Dr. Uttam Garg for his case on revision hip after hemi replacement in broken stem. Uttam Garg sir, is he over here?
Must be taking lunch, I'm sure.
Okay, so